As we are continuing with our discussion, hyponatremia. So in the previous video, we did say that when you have hyponatremia, which is a sodium of less than 135, like I said yesterday, that usually we don't really investigate these kind of patients when they've got a mild hyponatremia. We just manage them. But if it's severe and you really want to treat, you want to be sure what you're treating and all of that. So, so the approach that works best, that I've also used it myself, is you look at your hyponatremia and then you calculate your osmolality, plasma osmolality. So plasma osmolality, like we said yesterday, that it can be more than 290. When you calculate it, you can get a value that is more than 290, or it can be normal, which is it can be between 275 to 290, or it can be less than 275. When the osmolality is more than 290, by definition, so if you've got hyponatremia in the setting of hyponatremia, by definition, that is called hypertonic hyponatremia. Some people also call it hyperosmolar hyponatremia. On the other side, if it's less than 275, we call it hypotonic hyponatremia, or hypoosmolar hyponatremia. If it's normal, it's called pseudo hyponatremia, right? So the video that I uploaded, part one of this hyponatremia, clinical approach to a patient with hyponatremia, that video, I do explain there that when you've got hypertonic hyponatremia, your differentials are things like hyperglycemia, mannitol, which is a diuretic, glycine. So these substances are able to withdraw water. They are osmotically active. And in that video, I do explain how this happens. How does the shifting of the water and what actually causes the hyponatremia there. If I may just repeat it briefly. When you've got an osmotically active substance, that substance will draw water and that substance is gonna draw water from the intracellular space. The water that is leaving the intracellular space will be drawn into the extracellular fluid and into the intravascular. Now the sodium that you have in the extracellular space will be diluted by the fluid that is leaving the cells. Like so you've got this this glucose in the intravascular space. Now the sugar is gonna pull the intracellular fluid out into the extracellular compartment, or in the interstitial, and that water is gonna also move from there into the intravascular. Now basically, when you draw water out of these cells, you are going to dilute the sodium that you have here. Now you are going to have hyponatremia because you have diluted your sodium, because you are having a shift, or you are having shifting of water from the intracellular space into the extracellular space or cellular fluid. That's how you get that hypertonic hyponatremia. I did explain that yesterday. So let's talk about pseudo hyponatremia. Pseudo hyponatremia is a false hyponatremia. It's actually a lab error. You can't have hyponatremia when there is no change in the osmolality. If you understand how water moves from one compartment to another, how water moves from one compartment to another, from the interstitial to the intracellular, from the intracellular to the interstitial, it depends on the gradient. I explained this in the previous videos, that it depends on the concentration gradient of the solids across that membrane. Whether water is going to move into the interstitial fluid from the intracellular or vice versa, it depends on the osmolar or the osmotic gradient across that cell membrane. So if there is no change in osmolality, there won't be any net movement of water. So for you to have a shifting of water, you need, for you to have a net movement of water, you need a change in the gradient of the concentrations across that bilipid layer. So let's just talk about the conditions that give you pseudo hyponatremia. So the conditions that give you pseudo hyponatremia, it's things like hyperlipidemia, things like hyperproteinemia, so apparently in the lab there are various ways of calculating the concentration of sodium in the plasma. So there are techniques that give you a wrong reading. They give you a low a low sodium reading when the sample has got hyperproteinemia or when it has got hyperlipidemia. That's why it's called a lab error. So if you have got a patient who has hyperlipidemia or hyperproteinemia and you do their UNEs and you get hyponatremia, then you should call the lab to find out what technique did they use to check the concentration of sodium in your sample. If it's a technique that sort of like is known to give a false low reading of sodium in the presence of hyperlipidemia or in the presence of hyperproteinemia, then you should ask them to use another technique or another analyzer that is more selective, that will check correctly the level of your sodium. It doesn't mean that you will never have hyponatremia when you've got hyperproteinemia or when you've got hyperlipidemia, because you can have from other causes. But when you really suspect that your patient might be having true hyponatremia in the presence of hyperlipidemia or hyperproteinemia, then ask the lab to redo the test for you and use a different technique and see. But if you still get hyponatremia, then it means it's a true reading. But if the second test, the second analyzer that they use gives you a normal sodium, then it means that truly your head, the first machine was giving you a pseudo hyponatremia. So they call it pseudo hyponatremia. Okay, now we're gonna talk about hyponatremia in the presence of a hypoosmolar state.